An arrhythmia is a condition in which the heart beats with an irregular or abnormal rhythm. There's three different types. Paroxysmal is the first one. This is where the episodes stop within 48 hours of treatment. The second one is persistent. The irregular heartbeat lasts greater than 7 days. And then there is permanent, where the episodes are present all the time. Atrial fibrillation, or AF, is the name given to the condition where the heart rate is very fast. So normally, how the heart works is that the sinoatrial node sends electrical impulses from the atrium, causing it to contract and pump blood into the ventricles through a junction box called the atrioventricular node. The impulse spreads into the ventricles, causing the muscle to contract and to pump out the blood. So in atrial fibrillation, the electrical impulses do not originate in the sinoatrial node, but from a different part of the atrium or the nearby pulmonary veins. These abnormal electrical impulses, they become rapid and disorganized, radiating through the atrial walls in an uncoordinated manner. This can cause the walls of the atria to fibrillate or quiver. During atrial fibrillation, because the atria do not contract regularly, blood does not empty efficiently into the ventricles, and it begins to build up in the atria, which can cause blood clots. And if this blood clot breaks and enters the circulation, it can travel to the brain and cause a stroke or any other part of the body and cause a thromboembolism. And so the aim of the treatment in atrial fibrillation is to prevent complications such as stroke and venous thromboembolism. So one way to assess the risk of having stroke is to look at a CHADSVASc score. The CHADSVASc score stands for congestive heart failure, hypertension, age over 75, diabetes, stroke, vascular disease, age between 65 to 74, and the gender. If the patient's score is greater than or equal to 2, then they should be given an anticoagulant such as DOAC, warfarin, or heparin. So for example, if a patient has been diagnosed with AF and they have hypertension, they're over the age of 75 and have diabetes, their total score comes to 4, and so should be given a blood thinner. So atrial fibrillation can be managed by rate control or by rhythm control. Rate control tries to control the ventricular rate, and rhythm control tries to restore and maintain the sinus rhythm. To control ventricular rate, the first line preferred option is using a beta blocker, but not sotalol, because it's not cardioselective, or a rate-limiting calcium channel blocker such as diltiazem or verapamil. When a single drug fails to control the ventricular rate, a combination of two drugs, such as beta blocker, digoxin, or diltiazem can be used. Rhythm control is achieved using a beta blocker, and if a beta blocker is ineffective or not tolerated, an oral antiarrhythmic drug such as sotalol, Flecanide, or Amiodarone can be used. Antiarrhythmic drugs can be classified in those that act on supraventricular arrhythmias, which occur in the areas above the ventricles such as the atria. An example of this is verapamil. Then there is drugs that act only on ventricular arrhythmias such as lidocaine, and antiarrhythmic drugs which act on both supraventricular and ventricular arrhythmias, for example amiodarone. Another way of classifying them is through a Vaughan-Williams classification. There's 4 classes. Class 1 is membrane stabilizing drugs such as lidocaine and Flecanide. Class 2 is antisympathetic nervous system drugs such as beta blockers. Class 3 is amiodarone, which affect the potassium efflux. And Class 4 is calcium channel blockers, including verapamil, but not dihydropyridines. Amiodarone is one of the main antiarrhythmic drugs. It works by blocking voltage-gated potassium channels, which increase time for repolarization. This then decreases conduction through the atrioventricular and sinus node, which helps with the disorganized and uncoordinated electrical impulses. It has a very long half-life of several weeks and only needs to be given once a day. With amiodarone, it's very important to give a loading dose. So normally, 200 mg is given 3 times a day for 7 days, then reduced to 200 mg twice a day for 7 days, and then 200 mg once a day as a maintenance dose. However, amiodarone is toxic to the liver. It can cause hepatotoxicity. Because of this, the patient's liver function tests should be monitored before and every 6 months during treatment. And any signs of liver disease, such as nausea and vomiting, abdominal pain, jaundice, and an increase in LFTs by 3 times of the normal value should be reported, and the patient should be told to stop the amiodarone. Amiodarone can also affect the eyes and cause corneal microdeposits. This is reversible once the amiodarone is stopped, but the patient should be told that if driving, they may be dazzled by headlights at night. Amiodarone can also cause optic neuropathy, and therefore an eye test is recommended. And if there's any impairment in vision, the amiodarone should be stopped. Amiodarone can also affect the skin and cause phototoxicity. The skin should be shielded from sunlight using sun cream. Grey skin discoloration is also very common. Amiodarone can also cause peripheral neuropathy. It can also cause pneumonitis, and pneumonitis should be suspected if the patient develops a new cough or shortness of breath. Because of this, a chest X-ray is normally recommended when being on treatment with amiodarone. Amiodarone contains iodine, and this can affect the amount of iodine in your body and either cause hyper or hypothyroidism. Because of this, thyroid function tests should be monitored before the treatment and every 6 months during treatment with the amiodarone. If the patient experiences hypothyroidism, they will experience symptoms of weight loss, tachycardia, and heat intolerance, and it may be necessary to stop the amiodarone and start the patient on carbimazole. If the patient experiences hypothyroidism, they will have symptoms of weight gain, bradycardia, and cold intolerance, and it may be necessary to start the patient on levothyroxine. Amiodarone interacts with a lot of drugs. Amiodarone is an enzyme inhibitor, meaning it inhibits the enzymes that normally metabolize other drugs, such as warfarin, phenytoin, and digoxin. Because these drugs are not being metabolized when the patient is taking amiodarone, there is an increased concentration of them. So for example, you halve the dose of digoxin when the patient is also on amiodarone. There is also an increased risk of arrhythmias when amiodarone is taken with selective serotonin reuptake inhibitors and tricyclic antidepressants, lithium, quinines, and macrolides. There's also a risk of bradycardia if amiodarone is given with beta blockers or rate-limiting calcium channel blockers. There's also an increased risk of myopathy when taken with statin, such as simvastatins. And amiodarone should not be given in pregnancy and breastfeeding. Beta blockers block beta receptors in the heart, and by doing so, reduce cardiac output. However, they should not be used in patients with uncontrolled heart failure. Beta blockers can also act on the bronchi in the lungs and cause bronchospasm. Because of this, it should be used in caution or avoided in patients with asthma or COPD. However, if it is necessary to use beta blockers in these patients, cardioselective beta blockers should be used, such as nebivolol, atenolol, acebutolol, metoprolol, or bisoprolol. Some beta blockers, such as celiprolol, atenolol, nadolol, and sotalol, are water-soluble. This means they can't cross the blood-brain barrier, and because of this, they cause less sleep disturbances and nightmares. Due to their action on the liver and pancreas, beta blockers can affect carbohydrate metabolism, which may cause hyper or hypoglycemia, and so beta blockers should be used in caution with diabetic patients. Another drug that is used to control arrhythmias is the cardiac glycoside digoxin. It reduces the conductivity of the atrioventricular node. It has a very long half-life and is usually given once a day. If there is no benefit with this dose, it can be increased to twice a day, depending on the patient's kidney function, as the drug is cleared by the kidney. Liquid and tablet formulations of digoxin have different bioavailabilities, so if the formulation is interchanged, the dosing would also change. Something to be aware of is that if there is low potassium concentration, digoxin can become toxic. This is because normally digoxin binds to the ATPase pump on the same site as potassium. But when potassium levels are low, digoxin can bind more easily to this ATPase pump, causing a greater effect and digoxin toxicity. The way to overcome this is to try increasing the potassium concentration. This can be achieved in 3 ways, either using potassium sparing diuretics, potassium supplements, or foods with high potassium content. Symptoms of digoxin toxicity include nausea and vomiting, blurred and yellow vision, weight loss, anorexia, palpitations and hallucinations. In cases of severe digoxin toxicity, it may be necessary to give a digoxin-specific antibody fragment called Digifab, which binds to the free digoxin in the blood and inactivates it. Digoxin interacts with a lot of drugs, such as calcium channel blockers, rifampicin, amiodarone, St. John wort, erythromycin, and diuretics. The interaction either causes an increase or decrease in plasma digoxin concentration. If given with a diuretic, it increases the risk of hypokalemia and so digoxin toxicity.